down its original oral function?
Well, I appreciate very much the chance to come and talk with you about oral cancer. Of course, this is an extremely far-reaching topic for us because we have to remember that virtually any malignant process that affects the body can involve the oropharyngeal tissues, either by virtue of metastatic disease or by compromising the systemic health of the patient and ultimately resulting in a problem that needs to be treated. In addition, there are all of the tissues in the head and neck that are many tissues in the head and neck present elsewhere, and these give rise to the same neoplasms that they do anywhere else, such as osteogenic sarcomas and so forth. But I'm going to limit today's focus on, I'm going to talk about today the most common oral lesion that you're going to be dealing with, or a series of lesions, that being pre-neoplastic and neoplastic lesions that develop into carcinomas, and squamous cell carcinomas. The primary objective today is to sort of heighten your index of suspicion and to show you a few of the pitfalls that all of us can get into if we're not very careful and provide good descriptive information and clinical data to the pathologist so that we can arrive at a definitive diagnosis when we evaluate it histologically, which is the main thing I do, although I do carry a tube of xylactin in my pocket, so it's good stuff. Unfortunately, this is kind of the boring part of the day, but maybe it'll give you a chance to get a little shut-eye before the next lecture. Getting into this again, I want to talk about some of the things that go wrong that or potentially can go wrong to cause us to mistreat a patient. Dr. Osler once said to his residents that there are three important aspects of treatment. The first is diagnosis, the second is diagnosis, and the third is diagnosis. So if we don't make a definitive, accurate diagnosis, then it really doesn't matter what we do in the way of treatment. We're going to mess up at some point. So let's get on with it and talk about some of the lesions that you're going to be involved in treating. And remember, treatment includes the whole spectrum from initial observation to definitive diagnosis. We put the whole thing in as treatment. This is the earliest lesion that we see that may be considered precancerous, is so-called leukoplakia. Now, this is a boring term to most everyone in the room, and I only put it up here because I want to emphasize that this is terminology which is outdated and really should be totally abandoned. Leukoplakia used to be used years ago by pathologists to indicate a premalignant lesion. So when a clinician saw the diagnosis of leukoplakia, he automatically assumed he had a malignancy or a premalignant lesion. That's not the case any longer. Leukoplakia simply refers to a lesion which is clinically white. That's it. We still find, especially in our students, however, that there's a great deal of excitement when a patient shows up with a white lesion in the oropharyngeal areas as far as it being cancer. But the truth is, about 90% of white lesions are benign. Now, there are a few areas that we have to worry about white lesions in particular. That is a white lesion of the vermilion of the lip, a white lesion in the floor of the mouth, or a white lesion on the lateral border of the tongue that's not due to irritation by some form of problem with the dentition. Those are ones that we have to be suspect of, especially floor of mouth. But lesions such as this out on the buccal mucosa, orientation tongue here, buccal mucosa and retractor, just a very slight white hue here. These range all the way from just barely more colorful than the mucosa to just looking like a frankly white plaque of tissue. So I'd like to just remind you to be careful about the term leukoplakia, and when you get a report back from a pathologist, if he doesn't qualify it, he's just saying leukoplakia, you probably need to inquire and make sure that he's using that in the context of simple hyperkeratosis and nothing more, because there are still a few pathologists out there that do equate leukoplakia with dysplasia. Now, what we see histologically in leukoplakia is what I said, just simple hyperkeratosis, hyperorthokeratosis in this sense. You can see that the basal cell layer is well organized and intact, and that there is progressive maturation through the stratum spinosum to the stratum corneum with production of keratin at the top of the lesion. Again, conspicuous keratohyalin granules and orthokeratin. So that gets rid of leukoplakia, and we can move on a little bit. So hyperkeratosis is sort of the first thing. It implies irritation, and we can see hyperkeratosis as a consequence of smoking. As you know, the #1 risk factor in the development of oral cancer, as well as many others. But a lot of white lesions are simply hyperkeratosis. Now, we still have to follow the progression of all of these down, and so we're going to move our way through the ones we really have to worry about now, and conclude with some ones that trick us. This is a dysplastic lesion, and here you can see the difference between this and the hyperkeratosis is the fact that you have large nuclei here reaching into the middle 1/3 of the epithelium. So this would be classified as a moderate dysplastic lesion. Now, there's no cancer here. The reason the slash is here is because this is trying to indicate that dysplasia can progress on. This is definitely, when we see this in a patient who uses tobacco, smokeless, or smoked whatever, this patient could be in trouble. Here's a very large nucleus up here. So if the disturbance is confined to the lower 1/3, such as this division figure, and that's as high as it goes, it's mild dysplasia. If you see cells up in the middle 1/3, it is moderate. If it's almost full thickness, it's severe, and we'll get into that with this slide, which shows that we're getting progressively closer now to the neoplastic process. And by the way, even though this says ASCP, these are my slides. I borrowed this from a presentation I gave to the American Society of Clinical Pathologists, but since it was my own slide, I thought I could use it. This is the basal cell layer right here, and again, you can see these larger nuclei reaching up, and so this is a better case of a still moderate dysplasia. These large keratinocytes up here don't really disturb us too much. Now, over here, we're beginning to see some large cells with prominent nucleoli in the very superficial layers, so we're getting to severe dysplasia. Now, I'd like to take this time to indicate that you'll notice that as you lose maturation, you lose the ability to produce keratin. Therefore, what do you think this lesion is going to look like clinically? A white lesion or a red lesion? It's going to look red because the epithelial cells forget what they're programmed to do, which is to make keratin or to produce a nice thick layer for the non-keratinized oral tissues. And so, in general, it's the red lesion that we've really got to worry about, so-called erythroplasia, and I'll go over that in just a second. Now, here you can see, continuing to progress, this is about as severe a dysplastic process as you can get before we get into frank carcinoma. Now, here is carcinoma in situ. Now, this is the way we'd like to diagnose all carcinomas, because you can see that there has not yet been any breaking off from the basal cell layer of these malignant cells. This is a cancer for all practical purposes. It simply has not yet broken off so that it can get into the lymphatics and metastasize. So that is carcinoma in situ, and has to be fully excised with a margin of normal tissue in order to adequately treat it. And of course, when you see this, you have to look for its companion, because patients with one oral squamous cell carcinoma are at much greater risk to have a second primary, which is present either at the time that you see the first primary, or it can develop later on down the road. So when you see something as bad as this, look for something else. Very thorough examination is essential. And you can see again, this is not going to be a white lesion. This epithelium is thin. The blood vessels below are going to show through quite nicely, and it's going to be a red lesion most of the time. Now, if we begin to have cells that are breaking off of the basal cell layer, as you can see here, we're now developing into the earliest phases of invasive squamous cell carcinoma. Finally, full invasion into the tissues below gives us a frank squamous cell carcinoma, which is the topic of a lot of the therapeutic discussions you've had about treating this lesion. The most important thing, take home out of this sequence is that we have a great opportunity to intervene in patients with cancer. We've got a whole series of events that cause lesions that we can see if we just simply do good examinations. So we have the luxury of the lesions progressing through hyperkeratosis, mild, moderate, severe dysplasia, carcinoma in situ, and frank carcinoma. And they do progress through that. We don't see nearly as many lesions that just bloom out as squamous cell carcinoma de novo. Most of them go through this process. So it gives us a nice chance to intervene. Once we get to this point, we don't pat ourselves on the back too much for identifying that clinically, because if this patient has a lesion which looks like this clinically, they likely have a metastatic lesion to a lymph node, and prognosis goes down precipitously. So we back it up one, and we've got about a 90% 5-year survival rate. We can come up to here depending on site, and our survival rate can drop to 20. So it is critical that we find them early, as early as possible. Now, there are a few other lesions besides regular squamous cell carcinoma that we need to be aware of so that we don't miss a diagnosis. And one of the more recently described, this is just beginning to appear in the literature, is verrucous hyperkeratosis, or proliferative verrucous leukoplakia. As you might imagine, this is referring to a special form of leukoplakia that has a verrucous or warty-like surface, meaning a wrinkled type of surface. Again, I said it's a controversial terminology recently described, but the data indicates that if you see a white lesion with a great deal of irregularity to its surface, that one needs to be worried about more than your white lesion with a smooth surface. Now, it has a variable clinical and histologic appearance, and this one requires very close work between you and the pathologist in order to adequately diagnose it and treat it. You can see, though, that fortunately there are some distinguishing features that let us know this is not simple leukoplakia. Because of its verrucoid nature, the epithelium is more proliferative, thus it usually stands slightly above the surface by 1-2 millimeters. It has this convoluted, almost cerebriform or cauliflower surface to it, so that distinguishes it once again. So this is verrucous hyperkeratosis. Now also, we don't want to forget that the patient can have as many diseases as he or she pleases. So this patient also has zones of erythroplasia occurring anterior to the verrucous hyperkeratosis. So we also don't want to miss the fact that there is thinning going on here, and this turned out to be severe dysplasia with focal carcinoma in situ, and this turned out to just be verrucous leukoplakia. Okay. Now, if we look at it histologically, we have a lot of danger here if we just do a biopsy of this lesion and submit it to the pathologist and say, it's just a white lesion or a white patch. He needs to have his bell rung, or she, by saying this is verrucous leukoplakia. Has an irregular surface. It's thicker, because that will cue the pathologist in to the fact that it could be something more than a plain white patch. Indeed, note the increased thickness over the hyperkeratotic lesion I showed you earlier. So this lesion is proliferative verrucous leukoplakia because, one, it has more surface irregularity, They tend to be parakeratotic, that is retaining their nuclei in the upper surface, so it's a softer type of keratin when you palpate it. And there tends to be acanthosis or thickening in this due to proliferation of the cells in the middle of the epithelium. And there's also reserved cell hyperplasia, so you can see increased division figures in the basal cell area. So this one has the impression that it's cranking up, it's getting ready to do something. So we want to pay especially close attention to this lesion, because it can progress to this, which you can see correlates very well with the clinical appearance. It has this cauliflower or shape to it. You know, pathologists always refer to things as food because we don't make much money and we're hungry all the time, so that's why we refer to things in the context of food so much. But anyway, this has a verrucoid surface topography, but more disturbing than that, now in this lesion you can see that you're losing the zones. It's harder to find that basal cell layer and the superficial layer. Yes, we can see the keratosis here, but what I'm trying to say is there is now disturbance of maturation in this lesion. So we're moving on toward severe dysplasia, and we're going to eventually move into carcinoma in situ will be the next stage if we let this lesion incubate a little bit longer. So again, ounce of prevention. We want to get these and get them early. Are there any questions so far about the first couple? Other than how much longer is this going to go on? Okay. I'm sort of sensitive to that, you know. Teaching pathology, I've had to develop as there are some people in the room that have heard this before and are sick of it, but I have the Aufdemorte comatose scale, so I can assess how the audience is doing. And it's a 1 to 10 scale, and 1 is characterized by a little bit of lid lag. So the eyes are just beginning to close a tad. 2, there's a little bob to the head associated with the lid lag. Stage 3, the head's pretty well over and no longer bobby. 4 is over and down a little bit, and there's a positive drool sign. So you can get your notes messed up if you're not careful. And it just gets worse until finally we go outright comatose on the floor. And so I'm especially good at, I've had a lot of experience with that scale because I've induced almost every stage of it that there is. Okay, well, without further ado, we'll continue on into erythroplakia or erythroplasia. This used to be called erythroplasia of geri-ed because there was an erythematous red penile lesion that on biopsy was strictly carcinoma in situ. Well, it turns out that in the oral regions there's an identical type of lesion, and it also is carcinoma in situ. So erythroplakia or erythroplasia, I don't care what you call it, you must remember that it can correlate with this lesion, which is essentially carcinoma in situ. So oral erythroplakia is clinically and histologically similar to erythroplasia of geri-ed. The majority, as I said, demonstrate significant dysplasia or progression to frank carcinoma in situ. Here we go now. These are the lesions that you don't want to mess with. As soon as you see this lesion, you start beginning to get the scalpel ready, because this lesion means business, particularly the patient's a smoker. Although, don't be lulled into complacency if the patient is a non-smoker. I just diagnosed last week a squamous cell carcinoma in a 14-year-old girl who does not smoke, and I diagnosed a laryngeal carcinoma in a 9-year-old boy with no risk factors the week before that. Now, it was just I haven't seen that. It's extremely rare. We wonder what's going on with these individuals, and we're currently evaluating those tissues with DNA probes to see if we can find any human papillomavirus participation, because as you know, Cervical carcinomas are linked very strongly to the human papillomavirus serotypes. There are certain serotypes that cause them. In the oral cavity, however, most serotypes like 1, 6, 8, 10 produce simple squamous papillomas, are sometimes the so-called oral wart. But sooner or later, we're going to get a serotype of human papillomavirus that's going to be the one that's associated with carcinoma. So the mouth is further similar to the cervix. Well, I'll say dissimilar. It's similar in that oral lesions present with the same sequence from mild, moderate to severe dysplasia, carcinoma in situ, and squamous cell carcinoma. However, in the cervix, these lesions progress much more slowly than they do in the oropharyngeal areas. Therefore, pathologists sometimes, if they're not used to dealing with oral lesions, will look at a case of moderate dysplasia in the oral cavity as more or less not much of a big deal because in the cervix you have quite a bit of time to intervene in the clinical course. When you've got the slide read as moderate dysplasia in the oral regions, you've got to get to work because it's going to go. The second thing is that invariably all of my general pathology colleagues in my department will generally grade dysplastic lesions down one grade from what the oral head and neck pathologists such as myself do. Will invariably be off one notch, and they'll always be grading one scale lower. Although I should never say never and always avoid always. Okay, with that digression, boy, that was quite a bit off. We'll get back to erythroplasia if you still remember what we were talking about. Here again is a lesion of erythroplasia. And this unfortunate patient presented originally to her periodontist with a foreign body sensation. She felt like she had a popcorn hull or something stuck between her teeth. The periodontist curetted it out and sent a biopsy in, and we were concerned about it, but we couldn't diagnose carcinoma. He then tried to get her back, but she didn't return. And by the time she did return, a year later, it was a large fungating invasive squamous cell carcinoma with metastasis to 6 cervical chain lymph nodes. We had to do a hemiangioplasty and ultimately, unfortunately, lost the patient. Now, you can even see in this case here, you can see some areas of stippling, so the gingiva looks quite healthy. So things can be drastically wrong, though, down here. So the lesson to be learned from that is these are your most important follow-up patients. The very most important. You've got to be sure you get these folks back. If it takes contact by registered mail, certified mail, whatever, telephone calls, because a lot of times patients are cancer phobic and they don't want to come back. They don't want to face the fact they might have oral cancer. This is what the histology on this unfortunate lady looked like. You can see that it is a highly invasive, high-grade squamous cell carcinoma, fraying at the borders. And we also now grade carcinomas differently than we do many other neoplasms. Typically, pathologists grade carcinomas based on how many mitotic figures there are, how much pleomorphism or variation in nuclear size there is, how much variation in nuclear staining, but all that is off with squamous cells. With squamous cells, what you want to do when you're looking at that pathology report on your patient is see what the pathologist is describing at the periphery of the cell nest. If he's saying that the tumor is budding off as individual cells or single cells or Indian filing effect of cells, meaning the cells are crawling down through the collagen one behind the other, then those are all keys that this is a poorly differentiated squamous cell carcinoma and going to behave as such. Okay, let's get to a variation of carcinoma that is nice because this one is very slow growing. This is an indolent neoplasm that is most associated with long-term tobacco abuse, usually snuff, something of that sort. as well as age. So we rarely see this in young people. It's most common in the 6th decades on. However, the case I'm going to show you is a 5th decade, lady in her 5th decade of life. It was first reported intraorally as verrucous carcinoma of Ackerman. Extraoral sites, though, can be involved, including the larynx, vagina, rectal mucosa, and a number of other sites. Even the soles of the feet can have this peculiar variant of verrucous carcinoma. This is the one that I'm putting my money on for identifying a papillomavirus strain in it, such as is found in squamous interepithelial neoplasia of the cervix, or cervical dysplasia and carcinoma in situ. HPV 16 and 18 strains have been identified in oral lesions, so verrucous carcinoma is strongly correlated with those viruses. Now, the nice thing about verrucous carcinoma is that it is very slow in its growth pattern, and it, I shouldn't say never, but it never metastasizes. The only reports of metastatic verrucous carcinoma, if you'll go back and look at the histology very carefully, are those that have been irradiated, because somebody looked at the report, saw carcinoma, or the pathologist miscalled it and didn't recognize it as a verrucous carcinoma. And when you put a few rads on this, it's like pouring gasoline on fire. They take off and they invariably turn into extraordinarily ugly things and metastasize everywhere. So, with the exception of those cases that have been irradiated, verrucous carcinoma simply invades. And don't get me wrong, it can be quite destructive with a lot of morbidity and mortality just by virtue of continued growth and invasion, similar to the basal cell carcinoma of skin, which doesn't metastasize but can invade into your brain if left untreated. So this one can do the same thing. So again, we've got to diagnose it and get to it early. This is a patient that presented to a local dentist here in town, and she just wanted a denture made. And she was a little upset with him because he said, well, I don't want to make a denture right now. I want you to go and I want to do a biopsy of this and have it interpreted. So he sent the specimen over to me of the biopsy, and it was atypical verrucous carcinoma. Now here you can see this is much more irregular in its surface. But note how similar it is to a squamous papilloma. So that's why we really think these are papillomavirus associated. Now, the way you distinguish verrucous carcinoma from plain old squamous cell carcinoma is the fact that there's not going to be a lot of nuclear atypia, a tremendous amount of ugly looking cells. If there are, then it's just a variant of squamous cell. It's a verruciform squamous cell. So you got to be careful again, because pathologists may return a diagnosis to you of verruciform carcinoma. That's totally different than verrucous. Call him up, find out what he's talking about, because verruciform is going to behave just like any verrucous carcinoma, whereas this one's going to be a nice actor. You can see here, if you look down in these cells, you've got nice peripheral palisading in the basal cell layer. It's even trying to make some keratin centrally, but you don't have a lot of nuclear atypia in here. Not a lot of division figures and that sort of thing. So, if it looks bad histologically, then it's not verrucous carcinoma. If it looks pretty good, and in fact you're having a hard time telling what it is, that's a verrucous carcinoma. Now, another pitfall that we get into with verrucous carcinoma is one I saw during my pathology residency, and that was a case of a patient that had had 4, quote, papillomas excised from the mouth. Well, when you, in the same area. So when you have a recurrent squamous papilloma that comes back 4 times, or you have a lesion described as pseudoepitheliomatous hyperplasia, you need to think that could be a verrucous carcinoma, because papillomas can come back, but they're not going to keep coming back to that degree and coming back larger each time they do. So if you keep getting these redundant diagnoses, start thinking about, could this be a verrucous carcinoma? And I had one that came back 4 times, and it was a verrucous carcinoma. And when we went back and looked at the first slides, it was a verrucous carcinoma at that time. Okay, now let's talk about a few things that can really send us down the river pretty easily. Necrotizing sialometaplasia, first described by my mentor, Dr. John Cornyn, who was chief of oral head and neck cath at the AFIP for 8 years. He noticed this particular lesion with a peculiar clinical appearance that had a really good prognosis. So it just was funny to him that whenever he looked at squamous cell carcinomas of the palate or high-grade mucoepidermoid carcinomas of the palate, these patients were living and not dying of their disease as you'd expect. In addition, the palate, as you know, is a relatively uncommon site for for a squamous cell carcinoma. In fact, it's the least common site, the hard palate. So he went back and reviewed a lot of cases and came up with this term of necrotizing sialometaplasia, which is a totally benign lesion. The surgeon, in fact, has to hope that he can get an operating room very quickly because the lesion may be gone by the time he gets in there for the operation. Unfortunately, in this case, the patient wasn't quite so lucky. This is a patient that was stationed in Germany, and they did the biopsy on him, and it was read locally as invasive squamous cell carcinoma. They, as is customary, sent the slides to the AFIP, but remember, he's in Germany, and we didn't have fax machines and so forth when this case came through. And but we did have telephones, but I don't know what happened. It took a long time in transit. So by the time the AFIP saw it, called it necrotizing sialometaplasia, the patient had already had his hemimaxillectomy for this totally benign lesion. So be careful with any diagnosis of squamous cell carcinoma in the palate. Just double check. If your pathologist has his ego or whatever hurt a little bit by your inquiry, then tough. Okay. Now you can see it's nothing to be ashamed of to miss this diagnosis. I can take a 5th-year pathology resident or even our 6th-year fellows, put this out during an unknown case conference, and invariably almost 90% of our pathology residents and fellows even will miss it, even in their 5th year, because this doesn't look nice, does it? Certainly looks like it's breaking off from the surface. So you've got to really key in on some subtle features. And I know you all want to be histopathologists, but I'm going to forego the excruciating detail and suffice it to say that you can see necrotic salivary gland lobules. You can see the ghosts of where the lobules used to be, hence the term necrotizing. The lobular architecture is maintained. You can see this is still well circumscribed. Well, with a carcinoma, it's going to be invading out. So if you see dead and dying salivary glands, squamous metaplasia of the ducts, just meaning change in one cell type to another cell type, then you really need to start thinking about necrotizing sialometaplasia because of the metaplastic change here. So these are benign ducts. Right here you can see the simple columnar cells, but because of the irritation, it's developing squamous metaplasia, which can become quite florid and thus mistaken for 2 things: squamous cell carcinoma or a high-grade mucoepidermoid carcinoma. So got to really be careful of those areas. We think this lesion results from nothing more than an ischemic episode to the blood supply of the palate. We've seen it after injection of fairly large quantities of anesthetic with high concentrations of vasoconstrictors. It occurs with an increased incidence in smokers due to transient vasoconstriction that can occur there. And we'll see it sometimes after irradiation where there's been an obliterative endarteritis and we shut down the blood supply. So it can look kind of nasty, but still we have the lobules, and if you really come down, what I tell my residents is come down here and really look for the cytologic features of malignancy. They're not there. It's a benign lesion. So that's how we can diagnose it. As opposed to this character, this is a mucoepidermoid carcinoma, low grade of the palate. Note it has a lot of cystic components, a lot of mucinous debris in it. It's not well outlined, it's not circumscribed. It has some cells that look epidermoid, but it also has these mucus-containing cells, and then it has these clear cells, and necrotizing style metaplasia doesn't have these cells mixed in together. Now, I know you're saying, why in the world does he keep going on with all this junk, because it really doesn't make any difference. The thing, and I'd be thinking that too, the only thing I'm trying to do is, if I acquaint you with some of the pitfalls that we can make, then you tend to be a little more inquisitive of the pathologist relative to the diagnosis, rather than just accepting it as if you were Carnac, you know, with the envelope and divining the diagnosis. So these pathological types are human, and we screw up. So it doesn't hurt to, as a clinician, be on the lookout for that. Granular cell tumor, another case. Dick DeVille, the chief of dermatology here, always comes to me every year when he's giving his derm path course to borrow this case of granular cell tumor I've got, because he loves to sucker all the other dermatopathologists into calling this a squamous cell carcinoma too. It's a totally benign lesion of Schwann cell origin involving the tongue, but unfortunately it has this growing on top of it, and that can look quite nasty. This is a young lady I saw a while back that had a swelling in her tongue, and this is so benign that you don't even need to completely excise it. If you just make the diagnosis, you can leave it alone. It's nothing but a collection of these granular cells right here. So if you've got a report in your hands that says squamous cell carcinoma, and in the histologic description, you know, that worthless, boring part that we seldom read, if they do mention a granular cell component in there, and it's on the tongue especially, or larynx, then you need to think about a granular cell tumor. Again, immunohistochemistry has allowed us to tell these are Schwann cell or neural in origin rather than muscle. We can blow right by that. These things can nonetheless look very entertaining, and they can fortuitously be growing around small nerve bundles. And when you see that, that doesn't look right either. But the granular cell component doesn't bother us in that sense, because we know that's a benign lesion and it's just coincidentally overgrowing or growing around nerves. This is what gets you right here. Again, note these nests down very deep in the tissues that are keratinizing, and sometimes they've got fairly dark nuclei and so forth. So if you don't adhere strictly to your cytologic criteria for malignancy, you'll go down the drain, call it squamous cell carcinoma, and that's it. We've bought the farm. Again, this looks really bad, so I think you can see how even an excellent pathologist could miss this diagnosis. The clinician can save the day, though, by being aware of it. We've had dental hygienists, we've had physical therapists, we've had dentists, we've had everybody at some point in time question the diagnosis and been asked to re-review the slides, and sure enough, it's the granular cell tumor. Here again, it is too much histology naturally. Well, mercifully, we're nearing the end, and in record time too. Somehow I always talk too fast during these things, but sort of a mixed blessing. you don't understand or remember anything I said, but you don't have to sit there as long. Okay, the organ of Kivitz. I'll tell you a little bit about that one because it's another one that gets us into bad trouble. I saw this first published in the American Journal of Clinical Pathology back in 1978 when this unfortunate pathologist had been reviewing tissue from a biopsy down deep in the retromolar area or the pterygomandibular area. And he called that biopsy malignant, called it a squamous cell carcinoma because he saw these epithelial cells in intimate association with nerves. And it makes us nervous when we see epithelial cells associated with nerves. Now, in this region, this is the high-risk area. So again, if you've got a biopsy that's done on a little mass down in the pterygoid area, or if your patient just has vesiculobullous disease, and somehow the biopsy is done a little deep, and some of these tissues are included, so the pathologist says, your patient has pemphigoid or pemphigus vulgaris, but the really bad news is there's a carcinoma lying under it. And you know it's from the pterygomandibular area, you might want to question. Here again, you can see that a good pathologist can go awry on this. Here are the nests of cells. You'll recognize it quite readily as looking like odontogenic epithelial rests. So that background will help you. A general pathologist that has not seen these before will not. The reason they look like odontogenic rests is because they're derivatives of the same tissues. Odontogenesis occurs throughout the ridges of the oral cavity and leaves rests behind, a Malacea or Ceres rests, and this is the same phenomenon. Here again, epithelial cells. What's wrong with that for being a squamous cell carcinoma? Doesn't look bad, does it? Each nucleus is pretty much like the other nucleus. No cytologic features of malignancy. But note how that sucker can entwine itself around nerves, and within nerves, note, this is the real McCoy here. When you've got epithelial cells inside of nerves, all bets are off. That is a squamous cell carcinoma in the pterygomandibular area, and it's a very deceptive one because these cells tend to look much like the other two. But note that there is some keratinization going on in here, and the organ of Kivitz is not associated with keratinization. So this is a very neurotropic squamous cell, although well differentiated. Well, that concludes my little lecture. How many of you feel more rested now? I'm ready for the rest of the day. Okay. Well, at least I didn't come in right after lunch. I'll be happy to try and answer any questions or punt them off to somebody else who can, if there are any. Other than that, you probably just say, bring on the gong.